Hi, everyone. Welcome, welcome. Going to give a moment or two for people to join the call, and then we'll get started. Okay. Hi, everybody. My name is Rebecca Penn, and I'm the project manager for the Substance Use Health Network, and I'm really happy to be here with you all today. Thanks for taking time out of your day to join us for this webinar. I'd like to get us started in a good way, beginning with our with a land acknowledgement. So we come together today in this community of practice from across Turtle Island as people who live on treaty lands and ceded and unceded territories. We're all treaty people. In the spirit of truth, reconciliation, and respect, I'd like to acknowledge the land where I live, Sugum-Keegum, colonially known as Shelburne, Nova Scotia, which is part of the traditional and ongoing territories of the Mi'kmaq. We work in a sector whose goal is to address social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking. And we want to acknowledge that this continues in our day-to-day lives. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today, and we commit to working in ways that transform racist and colonial institutions and practices to repair harms, prevent future harms, and work towards a more inclusive and equitable future. I'd like to invite you to take a moment to reflect on your relationship with the land and with our obligations regarding reconciliation. If you'd like to say hello in the chat and let us know where you're coming from, where you're joining us from today, that would be great. So for those of you who are new to a Substance Use Health Network webinar, let me just give a quick introduction to who we are and what we do. So again, my name is Rebecca, and I'm the project manager, and the Substance Use Health Network is a community of practice that originated as the National Safer Supply Community Practice, but that has evolved to be focusing on a broader spectrum of substance use health. And our goal is to really build up an accessible, evidence-based continuum of substance use health care. We have just shy of 2,000 people from across Canada and outside of Canada who make up our membership. We have healthcare providers, social service workers, policymakers, leadership, researchers, and importantly, a large portion of our membership are people with lived and living experience. And the work that we do is around knowledge exchange and capacity building, and very importantly, also building a supportive community. This is tough work, and we're definitely stronger working together. If you are interested in joining us, you can go to our website and click join. You can take a snap of that QR code and find your way to our website there. And now I am very happy to pass it over to our guests today. We've been really excited about having this webinar. We have with us Farihah, Andrew, and Andrzej. Sorry, I just have a thing blocking my my screen there. So yeah, Andrzej, Andrew, and Farihah, we're really happy to have you talk about this work. I also just want to do a shout out to Tanya, who is helping with overseeing the chat and helping manage all the technical pieces today. Speaking of technical pieces, I didn't do our housekeeping. Very, very quickly, I want to let you know that we do have the chat open, and I see that there's lots of action happening there right now. Periodically through the webinar, Tanya or I will pop things in the chat that might be useful or interesting for you to share. There's also a question and answer box. That's a great spot to put any questions that you have for the panelists. And what we'll do is we'll have them do a bit of a presentation. They'll start with introducing themselves, do a presentation. Then we're going to have a really quick poll that I implore you to complete for me. And then we'll have a discussion. So if you pop any questions you have in the question and answer box, we'll be able to keep track of them and make sure that we can address those when we come to the discussion. Yeah, with that, I will turn it over to you, Andrzej, Andrew, and Farihah.
Thank you so much. I am going to go ahead and share my screen. Just ask for permission. Perfect. Can everyone see my screen? Amazing. Okay, well, hi everyone. Thank you so much for joining us. My name is Farihah, as introduced by Rebecca, and today we'll be presenting findings from our qualitative study. I won't make it without this program, the impact of safer opioid supply program closures in Ontario. The study was conducted as part of CRISM Ontario Node's ongoing work, and it focuses on the real-world impacts of these program closures on people who rely on them for safety and stability. So before I begin, I'd like to introduce two of my colleagues. I'll pass it over to Andrew, the research coordinator of this project.
Hi, everyone. Nice to see you all today. My name is Andrew. I'm a research coordinator with the Ontario node of CRISM, as well as the Institute for Mental Health Policy Research in CAMH. And over to Andrzej.
Hi, my name is Andrzej Celinski. I'm with the Reclaim Collective, and also, had the opportunity and great pleasure to collaborate with Farihah and Andrew on this project.
Thank you so much. So let's go ahead and begin. We really want to ensure that this is an engaging presentation and leave a lot of room for discussion. We really want to hear everyone's thoughts regarding, the results, but also next steps and implications. So I'll just start off with a little bit of a background. Not that I need to kind of share it, but let me provide some context as to why this project emerged. So Ontario continues to face a devastating toxic drug crisis. The unregulated drug supply has become increasingly unpredictable, contaminated with fentanyl, benzodiazepines, xylazines, making every use potentially fatal. In 2003 alone, over 2,500 people in Ontario died from opioid-related causes. These deaths are preventable, and safer supply programs have been one of the few interventions showing promise in reducing overdose deaths and improving quality of life. So what are safer opioid supply programs, or SSPs, or SOSs?
Hey, Farihah, so sorry to interrupt. The presentation isn't full screened.
Oh, it's not. Is it now?
Yeah, I think so for the most part. Yeah, it's just the slides aren't like full screened.
Oh, let me go here.
You can still see the top of your computers.
Yeah, let me see here. How do I make it full screen here?
Might be something saying like play slideshow or something like of that nature.
Farihah, I think it's a PDF.
Yeah, so my PowerPoint doesn't allow me to share a screen with Zoom, so I always have to convert it to PDFs.
Then it probably won't go full screen as easily in a slideshow kind of way.
Oh,
Oh,
here.
you might have to slide, move down a little bit.
Is this better?
Yeah, I think if you just zoomed like out a little bit, just to like kind of minimize the screen.
Okay,
Like
let
one
me
more,
see
it should
again.
be okay.
Let me see.
If anybody else has slides, you can email them to me and I can also share them.
So I did email them prior, so maybe let me try it again.
Not a big of a deal. I'm sure, like, we'll make do.
Is this better?
Yeah, like I think that's the full slide.
Yeah.
Is there anything below March 31st, 2025?
Oh, yes. Let me zoom out a
There
little.
we
Is
go.
that better, maybe?
Yeah,
Yes.
that should be
Okay.
perfect. Yep.
Let me go. Okay, perfect. Yeah, so safer opioid supply program, sorry about that. So essentially what they are, they provide pharmaceutical grade opioid medications to people who use drugs as a safer alternative to reduce reliance on the unregulated drug supply. So in 2020, Health Canada funded the implementation of these programs across Canada. And through the SUAP programs, the Substance Use and Addictions Program, there was 29 safer opioid supply programs were essentially established across the country, with 18 operating in Ontario. So the most funded programs operationalized in Ontario. However, what's interesting about these programs is that they were time limited, essentially looking to end their funding as of March 31st, 2025. These programs are typically embedded with community health centers, primary healthcare clinics, harm reduction sites, and they offer wraparound health and social support. So typically integrated with supervised consumption services. And evidence has repeatedly shown that these programs contribute to reducing overdose deaths, lower incidence of drug use related infections, so HIV, HCV, as well as improved quality of life for people who use drugs. So, as all of you may know, there's been an evolving policy context landscape in Ontario. Ontario enacted a Bill 223, the Safer Street Stronger Communities Act, which essentially prohibited supervised consumption sites to be operational within 200 meters of schools and childcare centers. It required provincial approval to operate any federally funded supervised consumption service within Ontario. And the reason why we're mentioning this bill is because, as I had mentioned, a lot of these safer opioid supply programs were already integrated within supervised consumption services. So, with the implementation of this bill, a lot of the programs also were impacted in terms of their closures. At the same time, the province introduced funding for heart hubs, though the homelessness and recovery treatment hub model, which essentially focused on prevention, treatment, and recovery and excluded harm reduction services, as I mentioned, like supervised consumption services, so safer opioid supply programs and needle exchange programs. So in addition to the funding being expired from SUAP on March 31st, 2025, we were also met with program closures because of the policy changes that were occurring in the province as well. So as a result, there was closure of 10 supervised consumption services in Ontario, which included 6 sites that were operating for opioid supply programs. And then the remaining programs were also at risk due to funding expirations as well as different policy restrictions. 9 of the 10 closing sites essentially converted to heart hubs, but there has been a provincial shift away from evidence-based harm reduction strategies, as I mentioned, the exclusion of safer opioid supply programs as well as supervised consumption service programs. So this brings us to why we conducted our study. So essentially, when we heard about the impending policy and impacts on these program closures as well as the funding, we really wanted to understand what the lived experiences and the needs of those directly affected by, these decisions are. So we really wanted to understand, how these closures undermine evidence-based harm reduction strategies and may potentially exacerbate the public health and social challenges already affected by the community. So our aim of this project was to explore safer opioid supply program clients' perspectives prior to program closure, including the role of these programs in their lives, the anticipated impacts on their health and well-being, and any strategies they may have used to cope with service disruptions at that time, so prior to closure. We conducted qualitative one-on-one interviews. So Andrew actually did all of the interviews virtually with program clients across Ontario between January 27th and February 10th, 2025. So prior to program closures. These interviews consisted of a brief socio-demographic survey followed by a semi-structured interview. And these interviews essentially explored participants' experiences with the program, any anticipated challenges and impacts related to the prospective closures, and any strategies, as I mentioned, they plan to adopt to reduce risks or access medications in response to the closures. Thinking about the data analysis, we analyzed that thematically. We had all our interviews transcribed and coded. And in terms of eligibility, they had to be enrolled in a safer opioid supply program for at least 6 months prior to participating in the interview. They had to be 18 years of age or older, and they had to speak English. We engaged in a number of different recruitment methods, such as convenience and snowball sampling, through existing partnerships with CRISM, as well as some of the provincial sites we were working with and that were very supportive of our research. So in terms of some key findings, before I pass it over to Andrew to share some of the qualitative findings, I'll just describe a little bit of our participant characteristics. We interviewed 25 clients. The average age was 44. 68% identified as Indigenous. The majority of our participants were housed. However, we did have individuals with unstable housing as well. In terms of, gender, and 48% were male, 48% were women, 4% were non-binary. 68% of our participants identified non-prescribed street opioids as their drug of choice, and 72% reported inhalation as their preferred route of administration. In terms of medications received, so all of our participants received Dilaudid, and then a number, 80% received Cadian, 72% received a combination of Cadian and Dilaudid, and a smaller percentage of our participants received methadone. Average time of enrollment in the program among our participants was 3 years, so really thinking about that long-term duration and engagement with these programs. 96% received take-home doses, 68% indicated that they picked up their medications at a pharmacy, and 56% of those mentioned daily pickups. Our participants represented 6 different programs across Ontario, and they identified accessing a number of different programs through their Safer Opioid Supply Program, with harm reduction, housing, and supervised consumption services as the top 3 at 64%, followed by other programs such as drug checking and primary care. So now I'll pass it over to Andrew to share a little bit about the qualitative findings that we heard.
Thank you very much, Farihah. So this next session will be an overview of our qualitative findings from the semi-structured interviews, reviewing some of the main benefits of the SOS programs and potential impacts of the closures on those benefits. Next slide, please. So first, we're going to look at drug use patterns. So clients reported SOS enrollment reduced their reliance on street drugs, shifted some clients' routes of administration from injection to either oral or inhalation, and increased stability across various domains of life, with one client noting, "I haven't used needles for a long time now." Clients feared SOS closures would reverse the progress they had made. As one client stated, "But if the pills are gone, I'm going to have to go back to the fentanyl." Next slide, please. Now we'll take a look at overdose risk reduction. So just over half of the clients reported no overdoses since their SOS enrollment. Decreased use of and reliance on street drugs was seen as a factor in overdose risk reduction among clients. One client stated bluntly, "Fentanyl probably would have killed me by now if I wasn't on SOS." A lot of access to SOS medication, paired with a decreased tolerance to highly potent, unregulated street drugs, was seen as a major risk for an increase in overdoses by clients, succinctly described as a death sentence. Next slide, please. So now we'll look at increased access to wraparound services as another high-level theme. So SOS program enrollment helped foster connection and engagement with wraparound services, providing many clients with a sense of community and improved health and well-being. SOS program closures led to clients fearing more than a discontinuation of their prescription, but also a disconnection from vital services and care. As one client explained, "It's not just getting your Dilaudid, it's your housing, your mental health." Next slide, please. So now we'll look at improved trust and engagement with healthcare systems. So SOS clients repeatedly discussed how their relationship with their SOS doctor and staff was built on honesty and trust, a truly novel experience for most. SOS closures generated deep concerns about having to go back to stigmatized treatment in healthcare settings. One client summed it up, saying, "With other medical professionals, I feel like I'm going to get judged if I speak like the truth, but not here. It's the best care I can get." Next slide, please. All right, so the next theme is quality of life improvements. So access to SOS medications often equated to a vast reduction in drug-seeking behaviors, an exchange of the time and energy spent accessing street drugs to other areas of their lives, generated improved finances, mental health, and relationships with friends and family. The notion of being forced back to that lifestyle caused great distress for several clients, with one openly discussing suicidal ideations, wondering aloud, how can they justify doing this? All right, next slide, please. So now we're going to look at some of the sort of strategies that were being mulled over as closures were impending, as these interviews were done right before the actual closures occurred. So consideration of opioid agonist treatment. Basically, a lot of the clients were having or being forced to consider going on OAT if they weren't going to be able to continue their prescription. A lot of clients viewed OAT as a last resort. They definitely preferred the alternative of maintaining their medication as prescribed, the Acadian, Dilaudid. Previous experiences engaging with OAT were all largely negative. There was quite a lot of discussion about negative past experiences due to the types of medication and punitive measures. Next slide, please. So another strategy that seemed to already be enacted in several different SOSs was either self-imposed or staff-imposed tapering off of medications. So in some cases, this was pretty drastic in terms of the amount of tablets they were receiving with Dilaudids. There was a vast reduction in the amount they were being prescribed per week. And this obviously has major issues regarding withdrawal, hospitalization, and also shifting towards a lot more high-risk coping strategies. So one client stated, "I started using again. I ended up in the hospital almost every other week because if they drop us 2 pills a week, and that's 2 pills in the morning and 2 pills in the evening dose. So I was feeling shitty, and as I would go out and just use anything like I could get my hands on, I wasn't even being careful where I bought my stuff. I was just mad." Next slide, please. Okay, and this is in regards to seeking other alternatives and navigating just the complete and utter uncertainty of what was going to happen next. So some participants were able to transition to alternative prescribers, though most faced deep uncertainty and limited options following program closures. So some did manage to transfer their prescriptions to either family doctors or integrated primary care clinics, ensuring continuity of their care. However, for most, there was no clear pathway to continuing the prescription, and that left a lot of participants in anxious and just confused states, honestly. So as one client put it, "I can't see myself living completely sober." And that was just the reality that a lot were having to grapple with in the moment during the interviews. And next slide, please. I believe I'm going to pass it over to Andrzej now.
Thanks, Andrew. Yeah, so from the perspective of people who use drugs, and there was a whole bunch of benefits to being on safe supply. You had the opportunity to stabilize kind of your drug use patterns. So rather than having to constantly rely on a street supply, you'd have a safe supply of something of known quantity and known quality and known purity. It also led to a reduction in involvement in potential criminal activities, or desperate situations that folks would have to kind of resort to at times obtain what is a very expensive, unregulated, and criminalized supply. Another great benefit to Safe Supply was through the community health centers. There was access to a whole bunch of wraparound services, a sense of community, counseling services, help with housing, help with finding jobs, access to drug testing supplies, access to supervised consumption sites, at the same places that folks were often getting their Safe Supply. And this obviously led to a decreased risk of overdose, and a sense of safety and psychological stability, ability to kind of travel, to focus on your job, to focus on just other parts of your life, rather than waking up in the morning being sick and having to worry about, okay, where am I going to get my fix for the day? And a lot of this led to like strong relationships with healthcare providers, and as I said, in a good sense of community at in these healthcare settings, especially for myself. Being someone who's involved in harm reduction, I made some great friends and connections at these sites. Next slide, please. Unfortunately, with the deprescribing, this led to a loss of the support and sense of family that folks experienced at these when they would get supply through community healthcare in community healthcare settings. And the deprescribing, I can say it was certainly like a scary time where there was a lot of uncertainty. Folks didn't know where they were going to go. There were some private options that a lot of folks were able to eventually get to, but there was certainly a lot of anxiety and stress that a lot of these this hard won progress and these gains made in harm reduction and drug policy would be lost, and all this progress made in individuals' recovery would be at risk. Next slide, please. Okay. Oh, sorry. And as I said, the loss of the wraparound services, including primary care access, mental health support, housing advocacy, food programs, and peer navigation, which were integrated into the models for many participants, was very difficult. Safe supply programs function not only as a medication access point, but as stabilizing hubs of care and community connection. When deprescribing occurs, people lose far more than prescribed medication. As I said, they lose trusted relationships, support of providers, and this can cause a cascading of instability. What I'm referring to is it can lead to housing loss, unmanaged health conditions getting worse, increased exposure to violence or criminalization, and profound emotional distress. From a person-centered perspective, the rupture represents a failure to uphold the core principles of harm reduction, meeting people where they are. Rather than supporting self-defined goals and well-being, deprescribing policies and service withdrawals recenter institutional priorities, cost containment, liability management, and political optics at the expense of individual and community health. Patients describe feeling erased from decision-making processes that directly affect their survival. The loss of wraparound supports turns once stabilizing care networks into fragmenting systems of exclusion, forcing people to navigate an underfunded and at times stigmatizing landscape on their own. This not only heightens overdose risk, but also deepens social marginalization, reinforcing the very inequities that safe supply programs were designed to reduce. Next slide, please. And the implications of SOS program closures are a loss of a proven public health safeguard. Closures risk undoing, as I said, a lot of these hard fought gains, safety, stability, and recovery, and as I said, are a disconnection from vital supports. And also leads to heightened economic and social costs, because as we know, money that's put into social programs has been shown in many cost-benefit analysis to have gains in the long term with decreased costs for policing, decreased costs of hospitalizations, and leads to unnecessary strain on an already strained healthcare and social welfare system. Next slide, please. And in terms of the community realities, a lot of folks, as I said, had to go to private healthcare settings, and with the wave of government-funded clinics closures and deprescribing in several provinces, it generated intensified forms of stigma. When programs are defunded and restructured, patients are often framed in public discourses as dependent on taxpayer-funded drugs or drug seeking, and not serious about recovery. These narratives repathologize participants and erase the harm reduction intent of safe supply. Patients being deprescribed or tapered off of safe supply without consent often describe the experience as resulting in a feeling of abandonment. Providers can justify discontinuation under pressure from regulatory colleges or shifting political climates. But for the patients, it results in facing increased withdrawal, destabilization, and renewed exposure to the toxic unregulated supply. This medicalized form of stigma, where people are made to feel undeserving of safety, merges with structural violence, leaving many to internalize shame or distrust the healthcare system altogether. Next slide, please. So with the path forward, you know, thankfully many folks have been able to find, you know, new options within like through private clinics, like and you know, I know a lot of folks have found like prescribers and doctors at some of these private clinics that, you know, have, you know, been able to provide the similar flexibility and quality of service in many instances that they previously received at the community healthcare centers. But at the same time, a lot of the wraparound services that folks once got, um, they no longer have access to. And I think it leads to some important questions, which, sorry, you know, and while at the same time, while on the one hand there are quality concerns, many which may, while we may prioritize those who can pay or those who seem as low risk as compliant, excluding marginalized people who use drugs, and the profit motive is now, you know, what guides the services at for-profit clinics, and this leads to the risks of commercialization of harm reduction, where continuity of care may depend on payment rather than need. And as well, and also there could be gaps in accountability, which, you know, weren't be as present in the community healthcare centers, but private clinics may operate outside of rigorous harm reduction ethics or community oversight, as well as the medicalization of harm reduction, where focus may shift towards individual treatment rather than systemic equality or decriminalization goals. So I think it's some questions to ask are, should safe supply be treated as a public health right, like clean water or primary care, or as a market service? And how can Canada prevent the privatization of harm reduction, similar to what's happened in parts of addiction treatment industry elsewhere? And what governance models best protect people who use drugs autonomy, accountability, community control while scaling access nationally? Thank you.
Thank you so much, Andre. And, you know, as we think about some of those questions that you posed, I'll just kind of wrap up our presentation by thinking about some policy considerations and next steps. So, obviously, we all know evidence-based decision making is critical, right? There's a lot of political rhetoric and discourse that surround harm reduction, which is inconsistent with data and evidence that we are collecting on the ground. It's based on ideology that perhaps favors ineffective punitive approaches, whereas the reality of the situation, when we, you know, look at the numbers or we look at the data from our qualitative interviews, we are seeing something that suggests quite differently than what political rhetoric as well as policy making directives move or gravitate towards. So as a result, there's obviously a need to conduct and continuously conduct robust long-term evaluations to adequately inform policy changes. We shouldn't give up, right? We need to continuously work together, work with community, work with researchers, services, organizations to collect the data that is so vital to inform these decision making. In terms of integrating treatment with harm reduction strategies, let's talk about this Heart Hub model. They aim to expand treatment access, but exclude critical harm reduction services. So participants in our study reported that OAT and other treatments have often failed them. They've failed to meet their needs. They are low barrier in terms of requirements. It's been very difficult to manage those requirements, which underscores the importance of flexible patient-centered models. So there's a need to maintain and scale up existing harm reduction programs alongside new treatment initiatives to ensure that these decisions and these treatment and harm reduction options are meeting people where they are at. So what are the next steps? And we'll talk a little bit about our partnership with CRISM's partnership with Reclaim and Andre specifically, and his team and Tanya. So what we're doing is right now we're doing a follow-up study. So this initial study where we presented our findings was pre-closure. So it was in February, but prior to the closure in March 31st. Now we're trying to understand what are the impacts of the closures now that these programs have actually closed. So looking to see, you know, who the clients who have been able to maintain access to safe opioid supply programs. And as Andre mentioned, that some of us have been fortunate enough to be able to, you know, find doctors or maintain their access to their prescriptions. So really trying to understand what are the mechanisms of access, what are the facilitators for ongoing access, what does continuity of medications and support mean to them? How did service transition look like? And what are the impacts on health and well-being? Because even though, clients have been able to maintain access to some of these prescriptions, they might not have been able to maintain access to the other wraparound services that are so vital to their journey. We also are interested in interviewing clients who lost access to safer opioid supply programs. What are their coping strategies? What have they done? What are their barriers to re-engagement and continuity of care? Have there been any changes to service utilization since the program has closed? And what are the impacts on their health and well-being? We're also looking at system level implications. So what are the shifts in health, social service utilization and demand? What are the impacts of disruptions and transitions on health and safety outcomes? And how does this feed into policy and system design considerations? So we are now recruiting participants. We are actually almost done our data collection, but this is a call to anyone that's interested in, sharing their perspectives and experiences with us. We're looking to interview anyone who has essentially been enrolled in a safer opioid supply program in Ontario prior to March 31st, 2025. We're thinking about those SUAP funded programs. We really want to learn more about how the closures of these programs have impacted the community, and how those transitions and coping mechanisms and strategies look like. Similar to this initial phase of our study, what does this phase look like? It's essentially a 10-minute survey looking kind of collecting some of that socio-demographic information, followed by a 30 to 60-minute interview with a member of our research team. All interviews are conducted over the phone or over online, so it's very virtual and flexible to accommodate everyone's needs. We are providing compensation for your time, so we send an e-transfer of $50 upon completion of the study. And of course, all information and data collected is confidential. It's de-identified, and participation will not affect any services that you are able to receive. So if you are interested in participating, there's the study email as well as a toll-free number. Please feel free to call or email us, and we'd be happy to set up a time to speak with you and learn more about your experiences. As you can see, none of this research is possible without the community. We want to hear from them. This study is community driven, and whatever data that we can collect to help inform and put pressure on the government and to informed policy and decision making is critical through this journey, especially as the policy continues, policy landscape continues to evolve, and harm reduction is not being prioritized as we would like it to be. These types of studies are extremely important. And before we open it up to discussion, I will probably just turn it back to Andrzej, who has been, we've partnered with Reclaim, as you mentioned, and just talk a little bit about this partnership and what kind of that means to Reclaim and to the community.
Yeah, it's been really great. And I really feel strongly about the importance of, meaningful collaboration with, people with lived experience and people who use drugs with, research organizations. And I really appreciate, all the opportunities and the manner in which CRISM and Farihah and Andrew and Kaylee have, interacted with the folks at Reclaim, with, what I've seen with other community members, and just really taken the time to be thoughtful, to provide opportunities for meaningful collaboration, and just, yeah, to really take an approach that I think is a kind of a model or and just a really positive experience for me compared to some other experiences I've had. So I really want to thank you for that, and just for being very gracious in this presentation, and just with all the collaborations that we've done together. So thank you.
Yeah, and I think just before we end off, Andrew and I would like to, as part of this research team, thank you and Reclaim and, anyone that has been involved in supporting recruitment and, thinking about helping inform some of our research design and questions. As I mentioned, this research is community driven and it comes from the community, and none of this work that we do, can be done without the community and without Andrzej, people like you and Tanya. So so yeah, just kind of want to conclude that. And, we've we've left a lot of room for discussion, and just hoping to have a really good, meaningful discussion and hopefully hear some of your experiences in regards to what we've shared today.
Can I just jump in real quick? It's Tanya here. I just wanted to as well reiterate what Andrzej said about working with Farihah and CRISM, and just one of the best experiences I've had and the most comfortable I've felt being included, and best practices. You just all of sort of our experiences so far working in collaboration has just been amazing, and we look forward to continue working together, as well as the same with Rebecca and our sort of co-facilitation with this community practice. It's just been amazing to be invited into spaces where we feel where we're valued and we actually have a voice, and our voices are amplified, and action, and there's action that's being taken because of our expertise and our lived experience being included. So thank you both to Farihah, CRISM, and Rebecca right now. Thank you.
Such a powerful presentation, and so lovely to have a little love in there at the end. But I also think it speaks so clearly to one of the points that you made in the presentation, which is about the importance of those relationships, right? And rebuilding trust and relationships between different institutional actors, be it healthcare providers or social service workers or researchers, as well as people who've experienced a lot of violence through our medical and social service systems. One of the things I thought a lot about with safer supply programs was that there was this opportunity to rebuild, restore, and do that. The word that's coming to my mind is like a reconciliation-y kind of thing. It completely different from the First Nations, Indigenous, Métis cultural, reconciliation. Please don't have me being confusing those two things, but just that trying to reorient the way things are done and acknowledge the expertise and goals amongst the communities of people who use drugs. Okay, let's have a discussion. If there is somebody who would like to speak, you can put your hand up and we can give you the power to speak. I'm not sure if that gives you the video or not, to be honest with you, but we welcome to open your mic so that your voice can be heard. You can also use the chat.
There are a few questions already in the question
Andrzej,
section.
I'm just getting to that. Two things first. So to finish my sentence there, you can also put questions in the Q&A box, and that way we'll get to those. Chat is something that everybody sees. Q&A are things that we will address as the panelists here. Before we start the Q&A, I am going to launch our poll. The poll is really helpful for us. We use the information from the poll to support applications for funding and things like that. Having funding allows us to do this work. It also helps us have the resources we need to justly as well as meaningfully engage people with lived and living experience. So appreciate your support in helping us do that work. And then but we can continue on while you're doing that poll. It shouldn't take too long. So let me open up the Q&A here, and we can get started at looking at some of those. So the first question is around Bill 10. Can somebody give a quick summary about what Bill 10 is? And the question here is asking what potential impact Bill 10 might have on folks who are people who might have been involved in safer supply.
Yeah, I mean, I can go ahead first, and then if anyone else wants to chime in, please feel free to do so. So Bill 10 is the Protecting Ontario Through Safer Streets and Stronger Communities Act. and it received royal assent. So essentially what this bill is, it enacted in Ontario, was enacted by our provincial government. It has lots of different schedules which amend a variety of acts, including a specific act which talks about which is perhaps most relevant to us, is the measures respecting premises with illegal drug activity, which is, I believe, Schedule 8. And that targets premises used for drug production and trafficking. So the bill essentially signals government's intent to tighten regulation around harm reduction services, specifically supervised consumption services. And in terms of like the impact that it has, because this legislation has set up conditions which force closures of supervised consumption services, there have been a number of closures. That we've already experienced. So a lot of these supervised consumption services, as I mentioned, have closed down because of the new bill, and then some of them have transitioned into heart hub models. So that's essentially how it has impacted us. It really essentially talks about how, thinking about the provision of where harm reduction services can be located within parameters and premises and radiuses close to childcare and daycare centers. Yeah, so that's what that bill is, and the closures of supervised consumption sites and subsequent safer opioid supply programs have impacted the community greatly. And simultaneously with this bill was the introduction of heart hub models. Andrew or Andre, anything else you'd like to add?
I think there's other. Oh, go ahead, Andrew.
No, I was just going to comment. I think it was also, I think they were referring to the encampments that have been dispersed as well. So it's basically just a continuation of removing and uprooting people's lives, dispersing them from their community. It's just decentralizing people who would normally be able to receive care and services that were like well-known areas that people were inhabiting and living in a community. That are now being forced to leave. I think I've seen it numerous times on the news where these encampments or they're just basically being bombarded by police and city workers, having their belongings thrown into the garbage. It's a continuation of the punitive measures by this government using that bill to enforce those powers.
Yeah, as Andrew said, it just like intensifies the feeling of like abandonment. There's, also it impacts dynamics between folks and the landlords. That's kind of outside of the realm of safe supply, but it just entrenches criminalization and just frames people who use drugs, more deeply within um, as something that needs to be managed, as a group that needs to be managed, and it doesn't do anything to help the stigmatization that people use drugs are already kind of feeling in these difficult times.
One of the things I think about a lot with the closure of the programs and passage of these bills is just, we know that periods of transition and change are periods of heightened risk for folks, even positive change, right? Any disruption in what people's routines and relationships and such are creates risk. And I think what we've seen over this past year has been a lot of different actions that have disrupted people's day-to-day lives, be it, even the transitions to a different care provider. It can be enormously stressful and again, put people at heightened risk. So it's very concerning. There's a question here about heart hubs and whether or not there have been any initial evaluations. And wondering about these evaluations, having some answers to questions like, who is using them? How many people are using them? What impacts have they had on the connection to treatment and access to other services? Realize it's early days for these, but yeah, does anybody know of any like very preliminary work in that regard?
Yeah, so Tanya and I have had the opportunity to work together. So at ChemH and CRISM, we're launching a needs assessment for the Heart Hub at Parkdale Queen West. So we're thinking about exactly, how does engagement and services look like with that specific site? How can we improve engagement? We're going to qualitatively interview clients that have engaged with that specific site, as well as clients that and community members that have not engaged with the Heart Hub, to see why. I mean, we know a lot of reasons why perhaps there might be disengagement, but to really further understand that rationale. And we're also going to be interviewing staff, a number of different staff, to understand what the operational aspect looked like. Were they involved in the design? Were community involved in the design of that specific Heart Hub? And then we're going to, our second phase to that is a focus group, where we were going to bring representatives from different Heart Hubs across the province to kind of feed back some of the information and see if the barriers and facilitators with this specific Heart Hub is reflective of what we're seeing across the province. And what the end goal is to really try and improve the Heart Hub model with the kind of the constraints that we have. So that is in early days. We are submitting to REB, but if anyone is interested, I'll put our CRISM website on in the chat. We routinely post recruitment for studies on there, so you can keep a lookout, or you can also sign up and be a member and become more privy to some of those research activities that we are doing.
Fantastic to know that work is happening. Question here, do the private clinics take OHIP? What is happening to the folks who are non-insured?
Andrzej or Tanya, do you want to take that?
I wouldn't know, like, off the top of my head. So, like, are we talking about people who do not have? I guess we're talking about people who are not covered by OHIP. Because as far as
Well,
I
the
know
first
on
part,
that,
go ahead.
as far as I know on that front, like from what I've seen at the clinics that I've gone to, you just have to pay out of pocket. Like, so there's going to be an additional charge if you don't have a valid health card. There's just going to be like an additional charge to see the doctor, just a whole bunch of additional charges as far as I know. So it's just an increased barrier. Yeah. That's really all I could speak to it. It's just going to amplify all of the kind of issues that folks are facing, would just be kind of amplified by, being uninsured. I don't know if anyone else wants to speak to it.
No, I would just agree with what Andrzej said as well. Yeah, just that's huge barriers. No, I don't know of any coverage through OHIP or anything that's covering the costs. So yeah, unfortunately.
Are there any stats on local changes in crime when SOS programs close?
Yeah, so that's a great question. We can speak a little bit to something in relation to supervised consumption services, more specifically. So Andrew and I are working with Toronto Public Health. They're conducting an evaluation, and we're looking to gather some of the data pre and post closure to assess essentially changes in crime around specifically the work site at Toronto Public Health. I'm not sure if we have the data yet or if it's forthcoming, but I'll pass it over to Andrew. But that's something that we're certainly looking at, because we want to be able to triangulate some of our findings, thinking about what's happening qualitatively, but then also looking at the number and the data that's being presented, like crime report data.
Yeah, for sure. So, I mean, in pertaining to the TPH study with the works, I basically have been able to triangulate localized crime within 100 meters using latitude and longitude from the open portal of crime data that Toronto Police Service does allow public access to. But in regards to like SOS programs specifically, I'm unaware of any studies that have been done specifically about that. They pretty much all pertain to SESs. So I know that there's some studies in the works that will be published soon that will be able to speak to that data. I believe there's one that is in the process of being published that looks at crime within 100 meters, 200 meters, and 400 meter radiuses around SESs in Ontario. So that data will be forthcoming, but SOSs I'm not particularly sure at this time.
I'll also pop in the chat in a moment the Ontario dashboard, which has other kinds of indicators, including mortality and EMS, and I believe is on there, and hospitalization. So I'll pop that in a moment. Another question here about quantitative research about this. Is there anything coming out that's quantitative?
Yeah, actually, I essentially just echo the previous comment and question. We're not completely sure. We are working on gathering some preliminary data to be able to triangulate some of our findings, but yeah, it's just forthcoming at this point. Yeah.
And a question here about court challenges. Is there anything happening in regard to court challenges to restrictions to access to safer supply and safer consumption sites?
Yeah, so I'm sure many of you know the neighborhood group. So along that group, along with some other individual applicants, they actually launched legal proceedings against the provincial government. And I think it was in March of this year, the Ontario Superior Court of Justice granted an injunction. But I think it remains open, to allow 10 supervised consumption services to remain open, but this is temporarily. And yeah, so the injunction is just temporary. The full constitutional decision hasn't yet been released yet. So thinking just about the final outcome, which may affect sites that stay open permanently or have to close or relocate. But not sure if anyone else may have more information to share about the TNG group's involvement in that
Well,
legal proceeding.
I think just important to differentiate that is just about the supervised
Yeah.
consumption sites, the CTSs, and not safer supply. The difficulty with something like safer supply is that it hasn't been there's no legislation saying you can't do safer supply. Any provider can provide safer supply. And there's been a shutdown on the provision of funding, and that's a different thing. That's a very hard thing to challenge in court. The challenge in Alberta was related to a change in legislation. So that's what makes that a bit different. And there's a really good webinar. I will add as one of our resources, because there's a really good webinar. I think it was CDPC and HIV Legal, maybe Katie, I can't remember, that a few organizations put together about doing legal challenges related to these kinds of policy shifts. So I will add that to our resource list that we post along with our videos. So you can find that there on our website in a couple days.
Yeah, thank you so much, Rebecca. That's a really important distinction to make about the supervised consumption service, because the policy, as you mentioned, was specifically about SCSs, CTSs. But why we speak about this in the conversation of safer opioid supply programs is that many of our other programs were integrated within SCSs and CTSs. So although the policy doesn't directly impact these programs, it indirectly impacts them. But then the main issue that it was impending was that funding through Health Canada Substance Use and Addictions Program. Right off the onset, they said it was a temporary funding period that was going to expire end of March anyways. So kind of thinking about how these programs are up against two battles. One is the funding issue from the federal government to actually support the sustainability of these programs, but then also the indirect issues related to the policy changes and the evolving policy landscape. But as Rebecca mentioned, like that if you are able to secure a prescriber, we've interviewed many people from the community that have continued their access to safer supply. So we're not seeing, and I don't want to speak for the whole community, from the sample that we have interviewed, the majority of our participants are still accessing safer supply through just different means, some of which are still accessing it through their same program, or their same prescriber. So yeah, that's a really important distinction to make note of.
And it'll be interesting to see there too, that if the model of care has shifted You know, there's the access to the medication, but there's also all the other pieces that go along with it, including primary care, including all the other wraparound services and supports. Lucas has a fantastic comment here, just wanting to echo everything that has been said in your presentation, and states, I've participated in a similar qualitative study with an SOS program before shutdowns. Our findings were very, very similar to what you've reported here, and this is reflected again in other work published on safer supply programs. The experiences talked about here have been incredibly consistent and widely reported across the board. I'm having a hard time finding the words to express how deeply disappointed and upset I am with these shutdowns. Thank you for doing this work, capturing what's happening before and after the shutdowns. Thank you, Lucas. A question here. Have you reached out to any other safe consumption sites about research they have done to support their sites staying open? Specifically, like Insight in Vancouver that survived multiple attempts by conservative governments to shut it down. So I think part of the answer to that question is what we were just talking about the different, and I'm not going to say it properly, but like the different, what's the wording, the legal wording? Somebody out there knows what I'm trying to say here, about like there's different criteria for being able to do a constitutional challenge, which is often what these are based on. The Insight challenge was around a constitutional challenge. And again, these ones don't qualify in that sense of it's not like a legislative thing, because the drugs that are prescribed in safer opioid supply programs or safer supply programs are legal regulated substances. So yeah. But yeah, anybody have other things to add to?
Yeah, I mean, CRISM is a national research network, so we have nodes across the country. We are working with different individuals from different provinces as well to kind of get those insights to help inform our studies as well. But I think the situation in Ontario is so unique. I think it just kind of going back to what Rebecca said in terms of the constitutional challenge. It's not a policy implication or a legislative change that's impacting specifically these programs. It's an indirect policy change as well as funding commitments. And those funding, from the federal government is not just specific to Ontario. It's like, Canada-wide. All SUAP funded programs lost their funding as of March 31st. So it's a really interesting but tricky area to navigate as we engage in research. And just trying to understand, what do these disruptions or transitions look like on the ground? And maybe even if they are able to maintain access to a prescriber and their safer supply, their dose might change, their medication might change, their access to wraparound services might change. So all of these implications are being taken into consideration as well, as we engage in our research.
And there are a number of studies happening across different places. There's another question here about, has there been any research to date on the possible impact of the closure on British Columbia's safer supply pilots? And I'll say, again, there are, echoing what you said, Farihah, is that there are a number of studies happening, CRISM and beyond, looking at this and taking it at different angles and using different methodologies. I'm so looking forward to reading the results and learning about how much it actually has shifted safer supply prescribing practice, or whether it is just caused it all to sort of fracture out so that there's just different providers doing it quietly without programmatic supports and without the funding, and also in a place that disconnects them from integrating into all the other forms of care that having them based in community health settings enabled. So yeah, it'll be really interesting to see what the impact of that is. I recall just here with the community practice that in 23, 24, and into 2025, we were seeing more and more private clinics starting to offer safer supply as we were seeing the funded community health center based clinics or programs losing their funding. So it's interesting to think what how that has changed the landscape and to what effect, right? So yeah, looking forward to that research. But just to go to the British Columbia piece, there's two pieces in British Columbia, right, that have shifted and at the more or less the same time. So the key thing I think in British Columbia, yes, the SUAP funding for safer supply pilot projects came to an end. SUAP funding is by legislation only allowed to be up to 5 years. And so these are only ever intended to be pilot projects that with the idea that if an intervention or a program or whatever is demonstrates that it's effective, then the provincial governments who are responsible for healthcare service delivery funding would then take up the funding of those programs, right? So funding for the SUAP didn't have another call for SUAP or for safer supply programs. Some programs may include some healthcare provision and a decision about how to move forward with care for somebody is between a patient and their healthcare provider. So they're, funding, ongoing funding of programs that involve healthcare providers might still include prescription of safer supply. But the other piece in BC is that there was a change in how safer supply patients were allowed to access medications, and that's really related to the daily dispense piece, right? So having to have witness dosing and things like that. So that interacts with people's ability to access medications in the way that they need and want to do. But we do have data. There is a BC dashboard, opioid dashboard, that also tracks the number of people who are receiving prescriptions for safer supply. And the truth is I haven't looked at it in a bit, but I know that it has declined a lot over the past couple of years. Any other questions for our panelists? Something that I would really love to do and hope that we will be able to do is I'm thinking in like March kind of thing, when it's been about a year, is see if we could put together like a town hall kind of deal. I am copying completely 100%. I'll be completely transparent about this. ODPRN has done some beautiful town hall events, and I really love how they do that. And I was thinking this would be a really great town hall to do and invite some different people who have different relationships to the work and have a conversation about where we are a year later, but also recognize that that's really challenging to do in the public as a public forum kind of thing, because of all kinds of different pieces. But yeah, in the new year, we'll start investigating how we might be able to approach sharing people's experiences and journeys. Although as we know, there's a lot of research coming our way, but yeah.
Yeah, and happy to come back, and if we're invited back to share some of the findings from this round of our data collection, to really kind of highlight what's happening post formal closure.
Yeah, I really look forward to having you back. We insist, actually. Name the date and we'll make it happen.
Perfect.
Let me just double check I don't see any other questions. Somebody got the heart emoji or whatever emoticon working. Thank you. don't have it turned on for everybody for responding to the in chats. I apologize for that, because you know, we all like to heart each other when we say good things. So I'll try to remember to do that for our next one. But yes, I agree with the clapping hands. Thank you so much to our panelists. Thank you, Tanya, for doing this with me today. And really grateful for your time, for your work, and your commitment to doing research on this topic and doing all the grant writing and paper writing that we need you to do to bring this out to the world. And also big thanks to everybody who took time to be here today. It's really great to have you join us, and we look forward to having more. We'll be starting to resume more engagement and webinars and such in the new year. We might be kind of quiet over the next couple of months, but we'll be back in the new year with some exciting new things. So yeah, any last comments from our panelists? Or from for people who are here with us, our attendees?
No, just thank you so much. Thank you to Andrzej and Tanya. Also, special shout out to Andrew. He conducted all the interviews, made amazing partnerships with community as well as the services. So, you know, a lot of this work, in fact, most of this work probably wouldn't be as successful if it wasn't for Andrew. So a shout out to Andrew for your commitment to this project as well.
I just want to say as well to Farihah and Andrew for joining us and putting this all together, and I do look forward to having you back for the stuff that we're working on. It's exciting and challenging and all things, but yeah, thank you, and thank you everyone who joined us today. And like I put in the chat, we're here weekly for discussion and connection. If you want to join us, yeah, hopefully we'll see you all again soon.
Excellent. And I will work on getting this, the recording and the resources up on our website on the weekend. So I can send out an email to everybody who registered saying that it's available. Yeah, on our website and our YouTube channel. Great. All right. I'm going to stop recording and say goodbye to everyone. Thank you so much for joining us.
Thanks, everyone.